Excellent. So, good morning, everyone. What are we? Just coming up to 10:05, 29th of August. Welcome to the BronchStop pre-season webinar. The part of the team are here, but Thomas Williams, who's been instrumental to this project, is on leave. In fact, he's probably on a plane just about to go on holiday as we speak, and does send his apologies. But we have Sean O'Hagan with us, who's going to be running through the nuts and bolts of this webinar. Sean is undertaking a PhD in this area and is going to be an instrumental part of the team for 25-26. Thank you to those of you who have been part of this endeavour since 2020 now. It's nearly 5 years, and it's been an amazing piece of work done without very little funding, but with the goodwill of research teams, in particular research nurses throughout all four of our devolved nations. I'm not going to say too much because I'm going to leave a lot of it to Sean, but I did want to make it clear that this wouldn't have been possible without the hard work of many people on this call. And we do appreciate that have been ups and downs, changes, but that has resulted in a number of publications and a national profile for Peruki in terms of the delivery of this piece of work. And as you'll see from the presentation, we've received both media plaudits and a lot of goodwill from the UK HSA, which is great news. So I really do thank you for all of that. In terms of the webinar, could I just make sure that people are muted where possible, apart from the speakers, and we will just run through the agenda as Sean's just about to describe. So Sean, I'm going to leave it to you. Thank you very much. Sean, you're muted, my end.
Okay, sorry, can you hear me okay? Perfect. So thanks very much, Damien, for the introduction, and thanks very much to everyone for joining. My name is Sean. I am an incoming doctoral fellow based within Queen's University, Belfast. So today is the pre-season webinar. Hopefully we'll give the opportunity to recap on some of the things that Damien was saying, the ground that we've already covered, and the impacts that BronchStart/BronchStop has had to date, and also to look to the upcoming season for some of the changes. So the agenda for today's webinar, firstly, we'll look from the last season at the research outputs and the impact of the study, and then I'll take time to highlight some of the updates for the next season of data collection and explain some of the rationale for that, including changes to the eligibility and also moving towards a fully consented study. I'll then move on to look at the case report form, which has had some updates as we've moved to Queen's University Belfast being the server that is holding the data for the next season. And with the changes in the scope of the BronchStop study for the next season, we'll make changes to the CRF. And then finally have the opportunity for some questions and answers, and hopefully be able to cover any issues that people have encountered to date. So some of this will be revision. Obviously, a lot of people involved in the call have contributed massively to the study. So starting with BronchStop, which launched in September of last year, which kind of coincided with when I joined the BronchStop study group, had a test negative design, and this aspect of the study was consented. And the primary objective was in keeping with
the UK. Yep. Sorry to interrupt. Just the slides are still not on presenter view and aren't moving forward.
Oh, okay, sorry. Is it easier if I just keep it like this, Damien?
Yeah, I mean it's readable, so that it's easier to move through. It's just yeah, that's fine.
Just in
You
case
just need
it
to remember to
doesn't.
click them forward. That's all.
Yeah, is that moving now?
Yeah.
Yeah. Okay. Yeah. Apologies for that. Yeah. So in keeping with the UK introducing the maternal RSV vaccine, the BronchStop study utilized the research infrastructure that was in place to study the vaccine effectiveness in the real world, and looking at the impact on RSV associated hospitalization amongst infants in the first 6 months of life. And then the secondary objectives were looking at levels of care, different treatment modalities, and also there was an embedded maternal survey to look at facilitators and barriers to vaccine uptake. And so, as you know, the maternal vaccine was introduced in Scotland from August the 12th of last year and September the 1st in England, Wales, and Northern Ireland. And with the help of a lot of the people that are on the call today, we were able to collect data from 30 hospital sites across England and Scotland. I'm happy to share that coming into this next season, it looks like we'll have Wales and Northern Ireland joining us. So that will truly be a four-nation study. And thinking about the research outputs from the last year, as Damien was alluding, one of the great benefits of BronchStop is that we've been able to really have a number of articles that were published and also impact on government policy. Um, we had a publication in the Lancet, Child and Adolescent Health, on the maternal vaccine effectiveness, and showed that for preventing hospitalization with RSV in infants and mothers who received the vaccination more than 2 weeks prior to delivery, the maternal vaccine was associated with a 72% reduction in hospitalization. Um, However, we weren't able to show difference in hospital outcomes, and this was likely related to the fact that the study was powered um, for the primary outcome of effectiveness against hospitalization, as opposed to these secondary outcomes that we were looking at in terms of treatment modalities and level of care. Within the study, we obviously had the embedded maternal survey, which was looking at predictors of maternal vaccine uptake and was based on the 5C model of vaccine hesitancy. So, based on confidence, calculation, convenience, complacency, and collective responsibility, all of these factors that involved in a decision to receive a vaccine. And we had approximately 700 maternal survey responses, and of these, 450 were free text responses, which we used in a thematic analysis, which we're hoping for to be published very shortly in the Archives of Disease of Childhood. And so the quantitative aspect of this was published in the Lancet Infectious Diseases, looking at maternal views of the RSV vaccine over the first season of implementation. So within this subset, just over 20% of the mothers were vaccinated and the vast majority were unvaccinated. And I guess the striking features were that a vast majority of those that were responding to the survey were confident that the RSV vaccine was necessary and safe. So the vast majority strongly agreed with those statements. However, access to the vaccine was established as an important issue. And for those that were unvaccinated, 35% of them strongly disagreed or disagreed with the fact that the vaccine was easy for them to get. So kind of established that there was a lot of work to be done in terms of access to vaccination. And I know a lot of you will have anecdotal stories that reflect this as well in terms of the difficulties that mothers encountered with trying to receive the RSV vaccine. And so we took this one step further and looking at the free text responses from the maternal surveys and undertook qualitative analysis under guidance from Dalia Iskander in UCL and Professor Kerry Wolfall based in Liverpool. And there were four principal themes that came out from this qualitative analysis, which were consistent across socio-demographic groups within the mothers that responded, and those were, and these are in kind of decreasing order of frequency. So access-related barriers to vaccination was the most prominent theme. Insufficient RSV awareness and information to support informed decision-making. Uh, Safety concerns and vaccine hesitancy grouped together were the next. And then a large portion also perceived the vaccine as beneficial and protective. And this publication has been submitted to the Archives of Disease in Childhood, as I discussed, and is currently under peer review. So we're hoping that that will be published in the coming months. And this will also inform the qualitative research that I'll undertake throughout my PhD, where I'll be conducting semi-structured interviews with mothers and fathers from across the UK, and looking at decision-making regarding the RSV maternal vaccine and barriers and facilitators to the uptake, to try and understand ways that we can encourage that through education and through targeted kind of campaigns. If there are any questions throughout, please raise your hand. I won't be able to see it, but hopefully Damien will be able to keep an eye. And then thinking about the impact of BronchStop from the last season. So the survey findings have been incorporated into ministerial briefing materials. The vaccine effectiveness results were communicated with the GCVI and data shared with the UKHSA and Public Health Scotland. I travelled to Bucharest and presented findings of the maternal survey at the European Society of Paediatric Infectious Diseases conference earlier in the year. Thomas Williams hosted a webinar with the Royal College of Midwives looking at the vaccine effectiveness results and maternal survey findings. And the study outcomes were featured in a number of national newspaper articles and public health campaigns, some of which are here. So the UKHSA had a publicity campaign for the RSV-Pre-F vaccine, which quoted the 72% effectiveness in preventing hospitalization for newborns from the BronchStop study. And the Sun newspaper highlighted the impacts of the vaccine on reducing hospitalization for babies against RSV. So it was really amazing to see how much this caught national headlines and newspapers, radio stations, and I think that all of that is a testament to everyone that was involved in the study. But I guess there's still plenty of work to be done, and that's reflected in the maternal RSV vaccine coverage across England. So there's a bit of a lag in the vaccine coverage data being released. So these are from February of this year, but the RSV vaccine coverage is sitting somewhere around kind of 55%. And obviously, you can see here, looking at coverage by ethnicity, there's a huge disparity in terms of maternal ethnicity and uptake of the vaccine, and that's also true of geographical locations. So there are pockets, particularly in London, where the uptake of the maternal vaccine is a lot lower than the rest of England. So there's still plenty of work to be done in terms of increasing uptake of the vaccine and access to those that to want to receive it. So thinking now about the next season of data collection, we'll talk through kind of the primary objective and some of the updates, and then hopefully technology working, I'll be able to take you through a demo of the case report form. So we are just submitting the updated protocol that was just recently submitted for publication for this next season of data collection. And the primary objective of the study is looking at the vaccine effectiveness when it is administered in a steady state of a vaccine program. So essentially, that's where the majority of mothers that are receiving the vaccine are receiving it close to 28 weeks gestation. Obviously, we recognize that the longer that it is received before delivery, the increase in time for transplacental transfer of maternal antibodies. And certainly in the Matisse trial, uh, uh, results from Argentina and also from BronchStop, at least 2 weeks before delivery is optimal for optimizing the effectiveness of the vaccine. So in this next season, when we should be approaching a steady state where there's less of a catch-up program and more mothers are receiving the vaccine closer to 28 weeks gestation, we'll be looking at the effectiveness of the vaccine in protecting against hospitalization, specifically in infants that are less than 6 months of age. And I guess the rationale behind this is that the UKHSA and Public Health Scotland are now leading on the RSV genomic surveillance, and specifically for older age groups, looking at kind of surveillance data. So one of the benefits of BronchStop has been the specificity and the ability to quickly calculate data and get that published. And we hope that this primary objective will help us to continue that. And as opposed to last season, where we're continuing to collect non-consented data up to 2 years. Now we're just focusing on consented participants only. And as I said earlier, the Red Cap is moving to be hosted in Queen's University Belfast for ease of administration of the study, because that's where I'm based. And because of that, we've made some updates to the case report form. And the ongoing questions for the next season are, what is the protection for older infants? So bearing in mind that the median age of infants in our first season was 1.4 months. So in this next season, we'll have the opportunity to look at protection in an older cohort of patients. We'll also look at whether mothers continue to have confidence in the vaccine and if there are ongoing barriers, if access to vaccination continues to be an issue despite the fact that it is now being rolled out for a year. And I'll further be exploring that throughout my PhD through qualitative interviews to gain a greater depth of insight. And then looking at what are the remaining causes of bronchiolitis in the post-vaccination era. So Thomas has done a lot of work on looking at virological testing of non-RSV causes of lower respiratory tract infection in this cohort. And we'll be undertaking genomic sequencing to look at when we reduce the rates of RSV bronchiolitis and what are the viral pathogens that emerge as more important and predominant. Perfect. So I guess the next thing that I wanted to move on to was a case report form demo. So I'll stop sharing and then hopefully be able to open up the red cap. And then in the interim, if there are any questions, hopefully between Damien and myself, we'll be able to field them. If anyone has any questions, pop them into the chat.
I've responded to one question, Sean, which was just about what has been done about informing maternity units, and there is a lot of national work and then some regional work on that. Is it going to be bold and strong enough? I don't know. And we know that really vaccine uptake isn't where it needs to be. But part of that is the challenge of giving vaccines to mums, because if you gave the vaccine to a child at a set point as part of a recognised vaccine schedule, that might make it a bit easier. And some of you will have known that from this morning's news, the chickenpox vaccine has been approved and will start in January 2026, and that is going to be merged with the MMR vaccine. So there's no additional burden on families. They're going to present to an MMR appointment and we'll get the chickenpox vaccine as well. That's not something we can do with RSV.
Yeah. Perfect. If people are happy, I'll reshare my screen and then we'll go through the CRF and I'll be able to highlight some changes. You see that okay, Damien?
Yep, that's working.
Perfect. So this is what the acute attendance form looks like now, and as we go along, you'll recognize that some things have changed. So the first page that you come to is the eligibility check, and so previously this was if the child was less than 2 years old. So if you click no here, it will now any of the options that you select, which would make someone ineligible. But participation will prompt you to end the survey if that's been the response. And then this is the same as last year, so same clinical diagnosis of bronchiolitis, LRTI, or first episode of wheeze, and then the same as in the last season, have they previously been enrolled in the study? And then if you collect all right things, they'll tell you if the child is eligible. And so this is a change from previous. Now you should be able to find your site from the list in the drop down. If you're unable to find it here, we can add it, and this should all be in alphabetical order to help you to find it. So I'll just go for Belfast. And now the 7-day follow-up will be linked to you'll get an email at day 7 to invite you to do the follow-up form. So pop your email in. And again, this is a change from the previous. So we'll now be using the study ID number, which will link to the locally held linkage log. So each site will have a 3-character code. For Belfast, it would be BAL, and then you'll sequentially enter the number, which is the next based on the locally held linkage log. And that will be rolling on from the last season, the number that you got to. And then pick of the 4 nations where you are. And then, so now, if you say maternal consent has not been provided, that will trigger the survey to be ended because it's a fully consented study. So we need to consent, and then that will open up the further identifiers that you're collecting. And based on the location that you've picked, so for Northern Ireland, it would be the health and social care number. In England and in Wales, it would be the NHS number, or in Scotland, this will prompt you to input the CHI number. So you can click on which of the identifiers that you're including: the mum, the maternal ethnicity. We have updated this question in terms of gender identity, and this was based on feedback that we received from the Lancet in terms of future publications. So hopefully it'll be straightforward enough. Just asking mothers if their gender identity is the same as it was assigned at birth. A new question that we've added is the estimated due date for the pregnancy. So we did a bit of public and patient involvement work in the lead up to this season to ask a group of mothers whether they felt that mothers would be able to recall their estimated due date. And this will allow us to better time when the RSV vaccine was received and the gestation at delivery. And the group were confident that mothers would be able to provide their EDD, breastfeeding, And then the next questions are drop downs around the whether the RSV vaccine in pregnancy was received. So if they answer that it was yes, whether they know the date, and then that will prompt to input the date. If they don't, then that's okay. And we now have a drop-down menu of weeks when the weeks of gestation when the RSV vaccine was received. And then in terms of the maternal survey questions, feedback that we received from the first season is that these first three questions around safety, necessity, and access were easily understood and reported by sites, but the questions related to collective responsibility were less well understood. So to reduce confusion for participants and difficulties for those that are collecting the data at sites, we've streamlined this to just include the three questions related to the maternal vaccine, so confidence, necessity, and access. So that hopefully will be easier for researchers to collect that information. This is the same as previous, and this is where we collected that qualitative data, which will hopefully be shortly published. So we really strongly encourage if you're able to include any further positive or negative responses that, or things that affected maternal decision making regarding whether or not to receive the vaccine, that will be really helpful. And then questions. So this is related to the interviews that I'll be undertaking as part of my PhD. So whether they consent to talk further, and then if so, provide the best contact number for them. And then we've added in whether they'd like to receive results of the study from the end of season webinar last year. What was fed back to us is that we didn't have a means by which to disseminate results of the study from the first season to the participants that wanted a plain English summary of the results. So we'll be more proactive in this next season to collect email addresses of those mothers which would like to receive the summary of the results from the study from this season. Hopefully this is all straightforward to cover, but certainly stop me or Damien if anyone puts up their hand, just let me know. And then again, because this is Northern Ireland, this is asking for an HSC number for the infant. If it was Scotland, it would be a CHI number, or England or Wales, it will be an NHS number. All of this is the same as in last season, so no changes here. I guess a change here is in terms of these are the criteria by which now that nirsevimab has been introduced for high-risk infants across the UK, we will now potentially be encountering infants that will have received nirsevimab, and we want to try and collect some data related to that as well. So if you click on one of these and you fill in these details, it will then prompt you as to whether they were offered the nirsevimab injection. If that was the case, then we've replicated the questions related to the maternal vaccine in terms of kind of safety, necessity, and access, and then again qualitative responses, free text responses in terms of factors that affected decision making about uptake of nirsevimab. And then if they were offered it, did they receive it? If they did, or if they didn't, why that was the case. And if they knew the date, if they did receive it, and then they can input that, and whether they were offered any other monoclonals, so palivizumab or clesrovimab. If you had answered that the child didn't have any comorbidities here, which would be the majority, then it would just go straight to asking you the gestation at birth. And you won't need to fill in any of the questions about nirsevimab. It will just be those higher risk groups that will be prompted. And again, this is the same as previous. The acute attendance kind of clinical data, and what viruses were tested for and what they tested positive for. And that's the end of the acute attendance CRF. So if any of those bits weren't clear, or if you want me to go back over any of that, just let me know.
Thanks, Sean. I've answered a few questions already just about being able to complete on paper, then upload, which isn't an ideal workflow, but is probably okay. And that also retrospective recruitment. We've always been keen for people to do it in real time because you get some of the better data that way, that you're not going to the notes. But again, retrospective data entry, especially at the weekends, is also a possibility. We're not against doing that, and that is it's not out with the scheme of the protocol. Louise has put a big question that I can't answer at the moment, is that last year, because we had this mix of consented and unconsented recruitment, you got accrual for consenting a patient, but you also got accrual for sending a sample away. Now that we're only doing consented, it might be perceived that that's one and the same thing because we consent the patient and send their sample. So whether we can double count that accrual, I'm not sure, but I will go and try and test that hypothesis with the NIHR. And then a good question from Gracita, which is probably an oversight on our part, but I think probably should stay in, is asking, previously we included anyone who also had first presentation viral wheeze. That's highly unlikely in the less than 6 month group. But I suppose it's not impossible, and is actually quite a good way of testing between departments where there perhaps is interesting either recruitment strategies or different age groups. So I wonder if we leave that in as almost an internal control. Sean, I don't know if you've got any thoughts on that. You're muted at the moment, but and you're still muted for me. I think you've got a bit of a delay on your microphone.
Sorry, I don't think I heard it properly. Sorry. So yeah, that's a great point, and that was actually brought up when we were updating the case report form. Thomas and I and Tom all discussed whether to keep that first week, because we were in agreement in the first 6 months of life. That's going to be a very small cohort of patients that would be the kind of diagnosis that they'll be classified with, as opposed to kind of a wheeze associated with bronchiolitis, etc. But felt that for continuity from the last season, and for the reason that Damien kind of just alluded to, that it was helpful to keep it in, but certainly something for us to look at. And if that's not a clinical diagnosis that is being used in this cohort, I guess that's something to think about for possible future seasons.
Yeah, thanks, Sean. So I think the thing is that question will remain in. I'm not suspecting people will use it, but we will be monitoring the use of that particular question.
Yeah.
Louise, also, are we still retaining only positive RSV samples? Now, I think any child who is consented, we should be sending, or I think we're sending samples for those patients, because Thomas wants some of the other data if they were positive for other things. Is that right, Sean?
Yeah, that's right. So it won't just be RSV positive samples. We are looking to try and look at non-RSV causes as well. So if we've had samples from them, I think there'll be specific sites that will be contributing to that work, but not just RSV positive samples.
Cool. And then a question, because the REDCap survey has moved to QUB, I think that someone's asking if you want to go back and look at all your COFs, not just on an individual patient, but just to review things. The link to do that, I think, will have changed because it will be under QUB. So we just need to remember to, we'll need to send that out, like the.
Okay.
but we'll sort that out,
You can put
Leanne.
that at the time.
Um,
Yeah.
and then Stephanie, yes, repeat admissions can be recruited, and it is useful to know who has returned. But I think there is a box in the survey that would alert the fact that you've been in previously. Is that right?
Yes. So if they've been in within the last month, then that would trigger it to say that they shouldn't be re-recruited. But it's if they've been in more than a month ago, then they can be recruited again.
So just while we wait for maybe other questions, Sean, was that on the agenda? Have we got? Is that what else were we going to run through, if anything?
The last thing was the Q&A. I will go back to screen sharing the presentation. So we've done the case report one demo, the Q&A, which we've kind of been doing. And then I guess the final thing, the slide won't work properly because the pictures are supposed to come up afterwards. I wonder, if I put this into slideshow mode, can you see that?
It's not moving to slideshow mode for me.
Okay. Well, essentially underneath the acknowledgements and thanks, the words that it says underneath the lovely photos of lots of groups of people that have collected data for us across the UK. It's just a thank you to the BronchStop Start team, to the patients and parents, to crew key clinicians, research nurses on the site, to Liz Whitaker, Connor Watson, and Kerry Wolfel, who've been involved. And then, yeah, I guess it's nicer to be able to see everyone's faces here from the different teams. And it would be great in this next season if you have photos. We'll probably at some point try and collect, because it's always really nice to see the large body of people that are contributing to the research that's being undertaken. And I guess the final thing is, yeah, just thanks very much for listening.
Thanks, Sean. So we've got plenty of time for further questions, but thank you for your summary of that. I mean, I think the key change is that the UK HSA have the ability to do some of this data analysis anyway. What we're trying to do is, and they have asked us in some ways to do this because we can collect the data quickly, then is target this under 6 month group who will give us the biggest information about the impact of the vaccine, particularly around how long the vaccine lasts for, and is its impact on 1 month olds the same as 6 month olds, for example. If we get a signal that there is capacity to go beyond 6 months, we will think about reviewing that. But for the moment, we're just going for the under 6 month old, all to be consented for the information that we need. Procedures asked, has the QR code changed or is the same? So now the QR code per site, I think, would be the same. But I don't know, Sean, when we've moved it over to QUB, is that going to need to reset everything?
So I think we've moved away from the QR code, I guess,
Yeah.
And that was in keeping with the fact that it's now a fully consented study. So the QR code was helpful in those non-consented patients, but because this will be consented and through that consent happening through the research teams,
so it'll just be the link. Fine. Yeah.
Yeah.
Okay. So what we will need to do is, I think, Sean, is send out, I think, site by site as they come on board, that the link, so everyone is clear of the things that they need to do. That's probably easy to do. And yes, and what this is Sarah's question is about. So it should be for infants who are admitted. One of the challenges is what counts as an admission because of the different way that admission units are used. We've always been a bit circumspect over this because we didn't want to get into a situation where it became difficult to recruit someone who shouldn't be recruited, or people were gaming the system and doing lots of recruits. Our feeling is the if you are recruited for essentially more than 12 or 18 hours, that probably is an admission. If you're sticking someone on your short stay unit just to check a couple of their next feeds and sending them home, that's not really an admission. And we are hoping that people will kind of follow that type of process. So if you're coming in and you are needing to be observed for a decent period of time, and there are minor interventions, that's an admission. If it simply is onto your short stay unit to observe the next two or feeds and check some stats, that's not. And hopefully that's a reasonable aid memoir. Joanne asks, is start date still beginning of September? Is no updated protocol? Yes, it is. There's nothing in the current protocol that doesn't allow you to do what we're doing. All we're doing is saying, please limit it to less than 6 months olds who are being admitted and you can get consent from. But we are updating the protocol to be very clear about that. Apologies, in an ideal world, this would all have been changed for the protocol and have been updated by now, but we are working at pace and we have been taking advice, especially people like Sean and Tom Williams, about what the best thing is to do for this season. And we didn't know that really up until the last couple of months, which is why it's a bit late from a governance point of view. But there is nothing in the current protocol that doesn't allow us to do what we're doing, so we can just roll on. I hope that's clear. Cool. We do. I mean, I don't know if people wanted to ask, kind of raise your hand and ask questions as well. It doesn't always need to be by the chat. Now, if you've got hospital at home, and someone is reviewing that patient at home, I think that is an admission and they can definitely be recruited. So I think that if someone's following them up, I think that's very reasonable. And are we using the same face-to-face consent forms and remote consent forms? You are for the moment, but we're going to update those slightly as part of an amendment.
What I would say to the hospital at home is, in terms of the levels of care, one of the options is other. So it would be helpful to collect, if you include that information, that it's a hospital at home service, that was one of the kind of levels of care that they received in terms of their treatment. And then I guess that's something that we can, it's better to have that knowledge when we're collecting that information.
Yeah, Sean, and Sarah's asked if the consent just to check for access to mother's maternal vaccination record. Yes, it is, but there is that. I think it's also probably just to clarify that, be clear about that we're probably going to send any sample, not just positive samples as well.
Yeah, so one of the changes will be that non-RSV samples, positive samples, could be sent for further testing.
Now we've already got agreement for that. That's actually come from the CAG, because it was agreed by a previous parent group that it would be reasonable to send samples of material of the patient. You're not sending a blood sample from the patient. You're not sending the patient's material. You're sending the virus from that patient, and that's why it was always felt that that would be a reasonable thing to do. But we're going to clarify in the next update that the kind of the consent will include that as well, even though we've got permission to do that. Good. Okay. So any other questions, either from the chat or by raising your hand? And I know we've got a reasonable group of people here, but as I say, I have recorded this. We will share this link. And if the AI works, we'll be able to share a summary of this meeting as well. Louise, no, so I'm not. I don't think we need to wait for the updated consent, because we had agreement to be able to do that even without taking consent previously. the ethics and the clinical advisory group that deals with that were happy with those samples to be sent, even without the parents knowing we'd done that. We just feel that if we're giving the opportunity to consent everyone, we should ask that. But we don't need to. We're just doing it because we're nice people and we feel we should. And yes, so we are currently PIS 1.3 and 1.4. John and Thomas are always confirming to me when we do the update, we're going to combine them into a common 1.5, so there's not this confusion between the forms.
So that it's clearer, the updated patient information sheet, the consent forms for face-to-face and telephone will all be version 1.5, and the updated protocol will be version 1.10. So hopefully, yeah, it won't be this case, but there are varying numbers, and that jumps ahead for some of them, but it's just for clarity.
Cool. Stephanie, you had your hand up. Had I answered the question?
Yeah, pretty much. I was just clarifying paper consent, obviously, before we complete the REDCap database. And I was just going to ask about the PIS and consent forms, which has already been clarified by Z. So thank you for that. And I was also then going to ask about confirming whether or not to send the samples from the first. Yes.
Yes, but I think the only thing that we probably, and this is, we'll have to meet and confirm this with Thomas Sean, is batching samples. I think that's what we've previously done. Most of the microbiology units have been happy just to hold on to these samples and be able to send them as a group, because that saves on transport costs.
Yeah, so I think typically Thomas has liaised directly with those labs to set up a kind of process for, as Damon was saying, a group, a bulk transfer of them. And yeah, so I think that shouldn't affect the research team that are kind of doing the frontline stuff, but Thomas will be kind of liaising with the laboratories and the specific hospitals that we're doing further testing of those throat and nose samples.
Okay, so thank you very much for the questions. That's useful to make sure that we've not missed anything major. What I will do is we'll hopefully send out this recording and a summary so you can share that with colleagues and for other people who have missed this, just to make sure we're not missing anything. The only thing that hasn't been, so clearly there is the update of the protocol and some of the consent forms. The thing that some people are a bit anxious about is that the amendment for the end date, which is the 27th of March 2026, still hasn't been completely processed. Now, in my view, that should not stop you starting, because we have got an amendment for sending out for the start date, but I know some research and governance departments like to have the end date before starting, and I am chasing that amendment, and as soon as we've got that, we will clearly send that out to sites. But hopefully people can start as soon as possible. I know locally I have a data form that sends me how many children have been admitted with bronchiolitis, and we are recording nil, max of 1 per day. So I don't think anything is happening at the moment, and it's going to be interesting to see. Normally what happens is we get nothing much in the first couple of weeks of September, and then you start to get a blip towards the end of September, rising October to peak in November. So I'm hopefully we've got enough time to capture the start of this. Sean, anything else you wanted to say that we've not covered?
No, that's perfect. I think there are a few emails I still need to get through in terms of assigning people to REDCap and to the data access groups, and I'll work through those. But yeah, otherwise, hopefully that's alleviated any concerns that people had and answered the questions, but happy to follow up in emails, ideally through the BronchStop study email address, and then you can kind of CC in personal emails, but that's just a shared email address that I won't be the only person that's reviewing, so it'll be helpful if that's the one that's used in the correspondence.
Brilliant. Okay, thank you very much. Well, I'll call things to a close there. As Sean's just mentioned too, please do ping emails through if you've got further questions, and we'll get a copy of this presentation out to you as soon as we can. Thanks all.
Thanks so much, guys. Take care.
Thank you.
Cheers.
Thanks. Bye.
Thanks a lot. Bye.